So the role of scleral buckle in management of primary retinal detachment is quite important, because I think almost 70 to 80% of the primary retinal detachments usually fall in the preview of possible management with scleral buckle. Though in the present era, with newer techniques and especially the popularity of vitrectomy with the good new equipments, it has probably slightly fallen back in popularity. But I think it's an art which we should all preserve, and it really works in most of the cases. So for me, I think the basic advantage, the principal advantage of using scleral buckle in management of primary rhegmatogenous retinal detachment is that it's more or less an extraocular procedure. It does not disturb the internal milieu, and it is suitable for all age groups. You can do it in an infant as well as in an old person, and it is very good for phakic RDs. The other important thing is the rapid retinal reattachment. So now detachment which has a definite break and a partial RD. I think it's straightforward. Or even if you have multiple breaks but a partial RD with no obvious PVR, again it's a good case to treat with scleral buckle. And if you have such breaks in superior temporal region with additional break here, you do the scleral buckle, and next day in 24 hours your retina is attached, and at 1 month a retina is absolutely fine. So it's if done properly, and if the case is selected properly, I think you get really gratifying results with scleral buckle. So for me, the indications would be a single or multiple buckles, which are definite. You know that you have seen the retina well, and you know these are the only breaks, and I think that is a good indication. Absence of significant PVR, any PVR less than C2 can be considered for a scleral buckle. Young phakic patients, it's always a procedure of choice. Aphakic patients with well-dilating pupil and clear vitreous, where you can see all the breaks well, I think also a good case to be operated with scleral buckle. And pseudophakic patients, again, where the pupil is well dilating, the vitreous is clear, and you can see the breaks. I think that's a good choice to consider scleral buckle. However, if the patient has such multiple breaks, margins, those are, I would not tend to consider this for a scleral buckle. And if there is definite PVR more than C2, no question of considering scleral buckle, and obviously an extreme PVR, so there is again no doubt that we should consider other possible surgeries. Here again, a giant dialysis following a cataract surgery, we avoid doing scleral buckle first. As Omar had rightly pointed, for pneumatic retinopathy, same applies for scleral buckle. Half the scleral buckle surgery is done before the operating. If the patient enters the operation theater, that means you have to do a very proper dilated indirect ophthalmoscopy, proper detailed drawing, and you should plan and only then go in and start the surgery. That helps in getting good results. So there's no two ways of avoiding this. You may not always do, a surgeon who has been practicing for a long time may not always do this unless he has a help from his fellow to do this detailed drawing. But at least he can make a quick drawing on his paper or on his chart. So that, because what happens sometimes is the patient may not come to you for surgery immediately. He will show you and then go back and come after 2-3 weeks. So I think going back to your notes would be helpful. And sometimes in the intermediate period, the patient develops synechiae, his cataract increases, the media gets hazy. So you don't know really what the primary situation was. So doing a drawing in the beginning when you see the patient for the first time is always helpful. And having a plan how to consider this surgery also helps in making your job easy. Usually, I prefer to do these cases under local anesthesia. Unless the patient is very apprehensive, we may add sedation. And for all children below 15, we would consider to do it under general anesthesia. Also, other one indication for general anesthesia are people who are claustrophobic. I have patients who just refuse to be draped at all. So in these patients, we may have to consider general anesthesia. So if you look at the steps, I'll just briefly go through them. Conjunctival peritomy is very important because in scleral buckle, you want the conjunctiva to cover all your buccal elements for life. So you can't take any chances with doing an FSZ job in opening the conjunctiva. It should be done very delicately and properly. And at the end of peritomy, you make 2 horizontal cuts. And once the peritomy is complete, you dithermize the bleeders and then go ahead with separating the intramuscular septums. Again, care being taken to use blunt instrument and not cause any trauma to the sclera in the entering process. Hooking the muscles also is important. You follow the sequence starting with the inferior rectus, then the 2 horizontal recta, and then the superior rectus. Always you prefer to use the blunt instrument so that you don't cause any trauma to the sclera in this beginning stage of the surgery. Once you identify the muscles, you may pass sutures to hold the muscles and move them around. And once all the muscles are, you check for any weakness. This is very important because if there is ectasia, you may have to change your plan. And I think Dr. Ashish will be talking about in more detail subsequently. Once you see with the use of indirect ophthalmoscopy, you mark the break. This is the area where I mark it with dithermy. You can use a marker or any other instrument you want to mark the break. It's a personal choice. And once that is done, here I'm demonstrating the implant technique. There is a choice of implant or an explant technique. It's a surgeon's own choice depending on his experience. The only thing which you have to be careful in an explant technique is that you take every suture which you take, especially in thin sclera, can potentially cause a scleral perforation. So you have to be very careful in selecting cases for explant techniques. In implant also, as I show, in this case, we see in subsequent slides, sometimes there can be still problems if you have a thin sclera. Once you have identified this break, you go about 3 millimeters on all sides, anterior, posterior, and on both sides, and make a scleral bed. And as you can see here, till this time that was okay, but at this point there was a little bit of scleral that it went full thickness, and the sclera has been the choroid has been popping out. But we could just still manage. So you can still manage these cases, and in the end we were able to place the buccal well. So once your bed is ready, you mark you check what buccal element you are going to put, decide the size, and then you make tunnels all around in the rest of the quadrants which you use for encircling elements. These tunnels are sutureless. You go all around, and once the tunnels are made, you pass sutures to hold your buccal element. And once that buccal element sutures are placed, you place the buccal along with the encircling element into the sutures, and then pass the sutures all around 360 degree. Once that is done, you make the bed. You can go back into the scleral bed and prepare the drainage side by dissecting the sclera till you see have the choroidal show. And once that is done, I prefer to use a 10 monofilament nylon needle, but you can use even a laser or any other dithermy tip to make the opening into the choroid. So this leads to drainage of the fluid, and once the drainage is complete, you may just tighten up the buccals. Now, this is a very critical step, the drainage, because you can get most of the complications at this stage. You can get hemorrhage from the drainage site, you can get hemorrhage under the retina. So selecting the drainage site, either in the bed, usually over the horizontal recti, is very important. And you should relax your pull on the muscles a little bit when you're just poking. And once you poke and your drainage is started, you would like to pull up the eyeball so that there is no sudden hypotony leading to choroidals in the inside of the eye. So once that is done, you tighten up the sutures, you pull up your encircling elements, and then tighten your encircling element also. After this is done, you immediately check the central retinal artery for any abnormal pulsations. You will digitally check the pressure. If it is high, you immediately take steps to reduce the pressure by loosening up the band. Once this is done, you are now back to your conjunctival areas. You see that the conjunctiva is pulled properly. You are covering all the buccal elements. Nothing is popping out. And then you go for the conjunctival suturing. You can use multiple techniques. I use a 6 or 8 Vicryl, but you can also use a glue, or you can use dithermize. You can dithermize the ends. It is personal choice. And this usually takes care of the surgery. Now, just a quick look on the intraoperative complications. Most of the steps in people who have been practicing this are safe, but you can cause globe perforation right at the local anesthesia injection. So you have to be careful, because many of these patients are high myopes. So if you're giving a block in a high myop, you have to be sure that you don't damage the sclera. And you can also cause globe perforation in thin scleras while marking the break. So don't use sharp instrument to mark the break. Scleral dissection can lead to problems. I have shown you just one of the slides. Sutures, if you're doing an explant technique, you have to be careful. Drainage can sometimes be dry, so you may have to select another site. Sometimes if the fluid is moving, you have to do multiple drainage sites. It can lead to hemorrhage, and it can lead to retinal incarceration. If the incarceration occurs in your buccal dissection itself, you can always get covered with the buccal itself. If it occurs in other sites, you will have to probably support it with a fresh buccal. Post drainage, there can also be hypotony, vitreous hemorrhage, and subretinal hemorrhage. You have to take care of that as soon as you do the surgery. Now, in one of the talks, we will be discussing about shifting from buccal to vitrectomy. One of the indications, if the hemorrhage is very severe, you may have to resort to doing a vitrectomy on table itself. Now, the early postoperative period, you may have raised IOP because most of the detachments, the patients have low IOP pre-surgery, and after you attach the retina, the pressure may go up. You have to be watchful for that. There may be choroidal detachments. If it is minimal, it can just slowly get covered, but sometimes you may have to resort to giving systemic steroids. Recurrent detachments in the early phase probably be due to a missed break or inadequate buccal, but in experienced hand, this is not a very common thing to occur. The only problem is of recurrent detachment will be in a later phase, which I'll see in the next slide. One important thing we should not miss is the ocular ischemic syndromes. If you tighten the buccal too much, and if you see in the post-op period that inflammation is not coming down as you expect, and if the pressure is remaining high, you have to think of ocular ischemic syndrome, especially in younger patients. And I've seen people with 6 and 6 vision, macula on RD losing their eye due to ocular ischemic syndrome. So you have to be very careful about this particular complication. Late postoperative complication would be again maintaining the IOP remaining high for a long time, recurrent detachment due to PVR and buccal infection. All this can be taken care of with other probable surgeries. So to conclude, scleral buccal, there is always been said it's a dying art. I don't think so. We have been using this. I have patients who have followed up even after 22 years and still maintaining a very good vision. So it's definitely, it has still a role to play in the current scenario. It has limitations, so your case selection has to be proper. And obviously there is an economic advantage because this is one surgery you can do with a very basic microscope, with a small, simple cryo. And obviously the cheapest instrument is always the surgeon who works for 24 hours. And as we can see, all of us are working for the last 25 years. So to end, this is just remembering exactly 6 years ago, at top of Zurich, these 3 musketeers are enjoying the view. We hope that we get such opportunity again. We are not meeting in person, but definitely today we are meeting virtually. Even Dr. Vatsal was there in Zurich that time, but not in this photograph. I hope we get this opportunity to meet directly someday in the near future. With this, I'll end my talk and I'll ask the next speaker to take over.